Welcome. In this explainer, we're diving into a high-yield masterclass on managing major trauma in the elderly. This is designed specifically for those of you studying for your final anesthesia exams. We're going to break down all the key challenges and the management principles you absolutely have to know, and it's all based on a really fantastic review article from BJA Education.
Okay, let's just jump right in with a number that really sets the stage for this entire discussion. 63.6 years. You know, back in 2020, that was the average age of a major trauma patient. Now think about this. Back in 1990, it was 36. That is a massive shift. The old idea of trauma as a young person's disease, well, that's officially over.
And this quote just illustrates that shift perfectly. We're not just talking about high-speed car crashes anymore. A simple fall from standing can be absolutely catastrophic. This has led to this new term you need to know, silver trauma. And believe me, it fundamentally changes how we have to think about these patients from the second they roll through the door. So, here's how we're going to tackle this. First, we'll look at this new reality of silver trauma. Then, we'll get into the really crucial stuff, the physiology of aging. After that, we'll apply all that knowledge with two case studies, one on traumatic brain injury and one on damage control resuscitation. And we'll wrap up with the vital topics of prognosis and ongoing care. So this new reality of silver trauma, what does that actually mean for us in practice? Well, it means our traditional ways of managing trauma often just don't cut it. The standard triage tools we've used for years, they were designed for younger people with high-energy injuries, and they often completely fail to pick up major injuries in the elderly because they rely on physiological signs that, as we're about to see, are often blunted or just not there at all.
Right, so this is the absolute key to understanding everything else. We have to know why these patients are so vulnerable, and it all boils down to the physiological changes that happen as we age. These changes shrink their physiological reserve and totally alter how they respond to injury. This is core knowledge for your exams, folks.
Let's start with the brain. As we age, the brain naturally shrinks a bit. That's cortical atrophy. This means there's actually more empty space inside the skull. So what happens? A patient can have a much larger intracranial bleed before you see any of the classic signs of raised pressure. This can lead to these terrifyingly delayed presentations of what is, in reality, a very severe head injury.
Now, this is fascinating, and it explains why the classic signs of shock can just vanish. Because of a dulled baroreceptor response, and often because they're on medications like beta blockers, an elderly patient who's bleeding out might have a completely normal heart rate. Their blood pressure might even look deceptively stable, right up until the moment they completely collapse.
Okay, think of this table as your high-yield summary, your cheat sheet, if you will. It covers all the crucial changes across the major organ systems. We're talking about everything from slower kidney function affecting your drug choices to a stiffer chest wall that makes a few rib fractures incredibly dangerous. This table is the fundamental why behind everything we see.
All right, enough theory. Let's apply this knowledge. Our first case is a super common presentation, but it's one that can easily catch you out if you're not prepared.
This case is an absolute classic. You've got a low-impact fall, a patient on a direct oral anticoagulant, or DOAC, and then a sudden drop in their level of consciousness. This isn't some subtle injury. This is a severe, rapidly expanding traumatic brain injury that was hiding in plain sight. That initial Glasgow Coma score, or GCS, of 14, it was dangerously and falsely reassuring. So what do? Your immediate priorities boil down to three critical steps. 1, you always have to have a high index of suspicion. 2, you must have a plan to rapidly reverse their anticoagulants. For warfarin, that's your prothrombin complex concentrate, or PCC, and vitamin K. For DOACs, you need to follow your local hematology guidelines. And 3, give tranexamic acid and give it early.
Now, for your exams, the key trial you have to be able to quote for using TXA in head injuries is CRASH 3. It's important to note that while it didn't show a mortality benefit across all severities, it absolutely did show a clear survival benefit when TXA was given early to patients with mild to moderate traumatic brain injuries.
All right, let's move to our second case. This one really ups the ante, bringing in the complexities of multiple injuries and major bleeding. So there's no ambiguity here. This patient is in profound hemorrhagic shock. Her blood pressure is in her boots, and she has life-threatening injuries. The number one priority is something called damage control resuscitation, or DCR.
You know, DCR is more than just a protocol. It's a whole philosophy of care. The goal is simple. Do the absolute minimum necessary in the ED to get the patient stable enough for definitive bleeding control, whether that's in the operating theater or interventional radiology. We are in a race against time, fighting to prevent that lethal triad of acidosis, hypothermia, and coagulopathy.
And when we talk about the balanced resuscitation part of DCR, the landmark trial you'll want to mention is the Perioperative trial. It's the evidence that supports using a 1-to-1-to-1 ratio of plasma, platelets, and red blood cells. The idea is to aggressively treat the trauma-induced coagulopathy right from the very beginning.
And now we get to what is probably the highest stakes moment for the anesthetist, inducing anesthesia in an unstable, bleeding, elderly trauma patient. This is an incredibly high-risk procedure, and it demands some serious, careful thought and preparation.
Before we jump to the next slide, just pause for a second and really think about this. How would your drug doses for our 72-year-old bleeding patient differ from the doses for our first patient, the 81-year-old with a hypertensive TBI? These are two vastly different physiological situations.
And this is just brilliant. This cognitive aid from the source article gives you a standardized approach. It literally shows you how to titrate your induction drugs, fentanyl, ketamine, and rocuronium, based on the patient's age, their frailty, and their cardiovascular stability. You go from full doses in a stable, hypertensive TBI patient, all the way down to maybe just rocuronium for a patient in traumatic cardiac arrest. It's all about reducing your cognitive load in a crisis.
Okay, so let's say the patient survives that initial chaotic resuscitation. The focus has a shift to the longer term. And this means thinking about prognosis, multidisciplinary care planning, and very often having some really difficult conversations with patients and their families.
The clinical frailty scale is an absolutely essential tool here. It helps us get past a patient's simple chronological age, the number of birthdays they've had, and helps us understand their physiological age. Frailty is an incredibly powerful, independent predictor of mortality and bad outcomes after major trauma, and this scale helps us actually put a number on it.
And to help us with those difficult conversations, we have specific scoring tools. You've got the Geriatric Trauma Outcome Score, or GTOS, which is really designed to predict the risk of dying in the hospital. Then you have the Trauma-Specific Frailty Index, or TSFI, which is much better at predicting where the patient might end up, so home versus a nursing home, for example. Both are invaluable for setting realistic expectations.
Okay, let's recap. If you take nothing else away, these are the exam essentials you need to have locked down. First, silver trauma from falls is the new normal. Second, remember that aging physiology hides the classic signs of shock. 3. Suspected TBI in any elderly patient after a fall. 4. Use damage control resuscitation with that 1-to-1-to-1 ratio. 5. Titrate your anesthetic drugs with extreme care. And finally, use those prognostic tools, the CFS, GTOs, and TSFI early to guide care and conversations.
At the end of the day, mastering this topic isn't just about passing an exam. It's about providing excellent, compassionate care to this rapidly growing and incredibly vulnerable group of patients. For a much deeper dive, the source article for this whole explainer is listed right here. Thanks so much for joining me.